together. We can be able to engage together and learn a lot this evening. It's 2 minutes to 7:30, and today we have the honor of having a meeting with Professor Juma Buika, and the topic will be about COPD. So in the next 1 minute, we encourage all our colleagues to join in and also silence on or mute our microphones. Those who wish to put their videos on, you're welcome to do so, as we have a fine engagement this evening. So exactly 7:30 p.m. Today we have the honors of being educated by Professor Juma Buika, who has accumulated 27 years practicing medicine since he qualified from the University of Nairobi in 1998. Professor Juma Buika is a clinical assistant professor, a section head and consultant pulmonologist at the Aga Khan University Hospital in Nairobi. His clinical interest is extensive and includes flexible bronchoscopy, non-invasive ventilation, thoracic ultrasonography for pleural procedures, medical thoracoscopy, cardiopulmonary exercise testing, and endobronchial ultrasound. We look forward to this insightful topic on COPD, chronic obstructive pulmonary airway disease, and we would like to welcome Dr. Buika. My name is Dr. Gunjiri. I'm a senior house officer practicing at Aga Khan Outreach Center in Thika, DC. You are welcome. Professor Buika, we have your attention. Thank you very much.
Thank you so much, Dr. Ngunjiri. I'll share my slides. I hope you can see them. In the interest of preserving bandwidth, I shall not share my video, but if there is a pressing need, then I'm more than happy to do that. So the remit was to speak about diagnosis and management of COPD, and this is the scope of what we shall cover. I think it's important that we look at COPD in the context of where we practice, that is Kenya. And I'll hopefully be able to share some data about this and very unique or very specific problems to our country. So it's important, and there isn't much about COPD in Kenya. There's a bit more about COPD in Africa than there is in Kenya. We know that COPD is the third cause for global mortality, behind strokes and ischemic heart disease. And it's been like that and has been rising for the past few years. Perhaps in the last decade, it's come up from number 4 to number 3, commonest cause for death in Africa, in the whole world. And 90% of all mortality from COPD occurs in low and middle income countries, including Kenya. And what is sad is that much of Africa accounts for more than a tenth of the global population. It bears more than 24% of the burden of COPD. So more than twice its fair share. And further, less than 1% of the global health budget is accounted for by sub-Saharan Africa. So we have double what we should have of COPD burden and have less than 1% of the entire global budget invested in management of health in total. And we know that besides mortality, there's a lot of morbidity from COPD, which you can extrapolate from sub-Saharan Africa to Kenya, and we expect that 1,000 to 15,000 deaths from COPD here in Kenya annually. There is some data looking at the prevalence of COPD in Africa, and if you look at about 13.4%. This is not very old data, and more recently, there was a systematic review that estimated COPD to affect between 7 and 19% of East Africans. That means about 11.3% of Kenyans have COPD. That's about 1 in every 9 Kenyans. So on average, out of every 9 Kenyans, 1 has COPD. But that's a lot more than most people think there is. And perhaps if you think about underdiagnosis and misdiagnosis, these numbers seem to make sense. My talk is going to heavily borrow from the GOLD guidelines. These are the Global Initiative for Chronic Obstructive Lung Disease guidelines. They are published and updated using very stringent evidence base almost annually, and they're the most widely used guidelines in the world for managing COPD. They are pretty much what GINA is for asthma. So we'll start with making the diagnosis. For us to discuss this well, we need to understand what COPD is. So it is a heterogeneous lung condition, and I shall talk a bit about this in 2 or 3 slides from now. But this condition is characterized by chronic respiratory symptoms. So dyspnea, which either at rest or on exertion, a cough that is chronic, chronic sputum production, and exacerbations of the infection, of the condition. And the features of COPD are damage to the airway, which is now what you'd call a bronchitis or bronchiolitis, and of the lung tissue, which is what we call emphysema. And there are many causes for COPD. Everybody thinks it's just smoking, but COPD comes about due to genetic predisposition, interaction between the host and the environment. So we're talking about poor air quality, tobacco, and the rest of it over time, primarily over a lifetime in many cases, but over a protracted period of time, right from the time of birth and lung development. The lung develops peaks. The lung development peaks at about 20 to 25 years of age. So any exposures before then can contribute towards COPD later, as can any exposures after that time. So commonly, the word used, which has been introduced, is getomics, i.e., genetic and environmental interactions of a lifetime. And when we say heterogeneous, it means there are different types of conditions that all can be classified as COPD. Much of this depends on the risk factors or exposures. So for instance, genetically determined COPD, these are people who have deficiency in alpha-1 antitrypsin. There are a few other genetic variants. These people develop COPD with very minimal exposure to poor air quality. And then there are children who are born before term or who are born with very low birth weight. They have developmental problems with their lungs, and they can develop COPD. And then there are exposures, environmental exposures to cigarette smoking, biomass fuel, and this also includes vaping. It includes the famous 420. It includes you not smoking but living with somebody who smokes in the same house, and other poor air quality exposures at place of work or where one lives. Okay, so people can get COPD due to infections. Famously, tuberculosis. We have a lot of COPD in in Africa, complicating properly diagnosed and properly cured tuberculosis. And asthma, again, is a very, very common and perhaps under recognized cause of COPD. When you do, well, some people have done cohort studies, longitudinal studies, and they found that people who never smoked, who have asthma, seem to have a lot more COPD later on in life compared to other people who've never smoked who do not have asthma. All these are risk factors for COPD, and they explain why we call it heterogeneous. So you start considering COPD as a diagnosis in people who have dyspnea. Usually this is progressive over time, exertional, and it's persistent. It's fairly insidious, and it may span 2, 3, 4 years before the patient actually complains of it. There may be recurrent wheeze, which usually coincides with bronchitis or exacerbations of COPD. A chronic cough is a cough that lasts more than 2 months. It may be intermittent and it may be non-productive. It's important to know there are many reasons why people have chronic cough. Current low respiratory tract infections, primarily because of the poor quality and increased vulnerability of the airway. There also is a recognized risk of history of risk factors or exposures, as we've just described in the preceding slide. We said there are many other reasons for chronic cough, so you need to take a good history and have a. There are many differential diagnoses for COPD. These are things that we all experience in our work. It's important, and it's possible to differentiate COPD from asthma from heart failure.